Welcome to this episode of Pocket Pearls. My name is Ghamar Bitar. I'm one of the residents at Christiana, and I'm here with Dr. Jain, one of our maternal fetal medicine physicians. Today we're here to talk about the Prolong study. Dr. Jain, can you tell me a little bit about what this study is about?
Okay, so the Prolong study stands for 17P to prevent recurrent preterm birth in singleton gestations. The study was really important because we've been waiting for a while to see the outcome or the efficacy of 17P in women with a history of prior preterm birth. Since the majority of our recommendations and sort of clinical guidance and counseling has all been based on a single study done in 2003, which is the MEIS trial. So this was a very anticipated study, and I think a lot of SMFM membership and MFM physicians were looking forward to seeing the results of this study.
Okay, and I imagine that the MEIS trial has supported that 17-OHP helps in prevention of preterm birth.
Exactly. The MEIS trial was probably one of the most significant trials in changing how we managed preterm birth. So in general, whenever we see a woman with a history of prior preterm birth, there's always 4 options that we go through with them about prevention of a recurrent preterm birth. One would be progesterone of some sort, and there's 2 formulations of progesterone, vaginal progesterone and intramuscular or subcutaneous 17-OHP. We talk about cerclage. In recent years, some of us have started talking about the pessary. And then we just talk about expectant management, and perhaps that if they've only had one preterm birth, or depending on the gestational age of the prior preterm birth, their risk of recurrence is sufficiently low that maybe we're only going to do cervical length screening, or we're not going to do anything. But there's just a lot of counseling that goes into it when we're trying to decide what the best plan of action is for a patient.
Okay, and so Prolong was a randomized control trial, multi-center across many countries. What kind of findings did it have?
So the reason why Prolong stirred up so much commotion, and I'm sure anyone who's been on social media platforms recently, who's followed the news, I understand there was an AMA alert about it, is that it showed very discrepant results from the MEIS trial. And so if you think about it, the MEIS trial was published in 2003. It is now 2019. So for 16 years, we have managed preterm birth this way, where SMFM has gone so far in it to say that the recommended treatment options for a woman with a prior history of preterm birth with a delivery prior to 37 weeks and a current singleton should be offered 17P. And we've done this for so long. So the issue is now you have this trial that is, quite impressive, like you said, multi-center, randomized, double-blind control, all the things we would look for, and yet it found no benefit. And that was shocking, because I think all of us were expecting that it would definitely, probably robustly support the MEIS trial. Why wouldn't it?
Right.
So now the commotion or the interest on social media is the dissection of the trial. So what makes it different, or why could it be different? Why would the results be so discrepant? Is there something going on with the patient demographics?
Sure.
Is there something going on with the enrollment? Was the statistical analysis not correct? But the FDA's job is to take that information and make a decision about the safety of a medication, and especially in pregnancy, the safety of a medication in pregnancy. And so that has been out on social media the last week or so, and culminated with the FDA vote that happened on Tuesday.
Yeah, and my understanding of 17-OHP is that there are really no adverse side effects known in pregnancy. The few studies that have evaluated it have shown that there's no significant harm to continuing using it.
Yeah, and I would say, it's not entirely benign. So there have been some case reports, some people have documented mixed results about whether it increases the risk for gestational diabetes or not. In certain populations, it has been shown to increase the risk. In other studies, it has never been shown to increase risk. I believe the package insert itself also talks about a slightly increased risk for miscarriage and loss in the first and early second trimesters, and then it also talks about a risk for venous thromboembolism. Again, never fully borne out in the randomized control trial, and they didn't necessarily see those risks in the MEIS trial, but it was not studied, so that has always been an argument. Now, that wasn't the primary focus of Prolong either. It wasn't to look at adverse effects
Sure.
of 17P. It was looking to see if 17P could prevent preterm birth or reduce the risk of recurrence of preterm birth. So again, not a study designed to really look at adverse effects of 17P. But in the 16, 17 years people have been using this, and even prior to 2003. So let's say in the last 20 years that we've given progesterone to women in some form, oral, intramuscular, sub-Q, vaginal. I mean, we've used progesterone in women's healthcare for years and years and years. There hasn't really been clear adverse side effects. So yes,
Okay.
in general, probably it's a very safe drug, but, you know, nothing is entirely 100% safe in pregnancy.
Sure.
So it is reasonable, especially when the FDA is making rules for use in pregnancy, that they should be cautious and evaluate all the data.
Sure. And you briefly touched on the difference in possibly the patient demographics or the populations in both the MEAS trial and the Prolong trial. Can you go into a little bit more detail about that?
Yeah, I think the MEAS trial, the rate of recurrent preterm birth, women who'd had 2 or more prior preterm deliveries, was well over 50% that they would have a recurrent third delivery. The recurrence rate for preterm birth in the Prolong study was much lower. It was 11%. So people right away were like, well, that's unusual. And then the demographics was one of the big concerns, mostly relating to race characteristics, with the MEAS trial being predominantly African American and this new Prolong trial being predominantly Caucasian. And then there were differences in demographics with smoking. Mm-hmm. And any of you who have covered PIP clinic with Dr. Rustaller know that she recommends, you know, tobacco cessation for anybody with a history of prior preterm birth, because we feel like that could be an additive risk factor. So it's hard to compare the two studies like that because they're not exactly the same population. And that's kind of when people are dissecting it, that is one of the arguments. You know, could it be that 17p in certain patient populations, very specific demographics, could this be an effective therapy? We don't know who that patient population is. And what are those patient characteristics that would determine someone to be a good candidate for 17p versus a bad candidate, or an ineffective therapy in that candidate?
And are SMFM and ACOG kind of on board with taking each patient case by case and providing individualized care, or are they hopeful to stop using 17-HP?
Yeah, I think, so we've seen two statements essentially come out, one from the ACOG, and so one from the college and then one from the Society of Maternal Fetal Medicine. I think ACOG sort of seemed to imply it's okay if you want to keep giving 17p. I thought the society, the SMFM's opinion was a little bit more nuanced, where they sort of said, look, you should counsel, it should be a case by case, it should be very individualized, you certainly should counsel the patient about all of their options. So I think for most of us, it's probably not going to change our counseling that much. Okay. I am still going to counsel. There are 4 methods of preterm birth prevention. Progesterone in 2 forms, so that's 2 of them, cerclage and pessary. The only difference might be that when talking about IM progesterone, I think I will probably mention 2 trials. Like normally I say, we're going to do this based on the MEAS trial published in 2003, and we're going to follow that protocol. You're going to get 17p starting at 16 weeks. It's going to go to 36. We're going to follow your cervix. You'll get a cerclage if these things happen. I think now one thing that I might change would be explaining to patients a little bit more in depth. So we had this one study in 2003. We have done it this way for the last 16 years. We have this new study, different patient population. There were different patient demographics. It shows maybe there isn't a benefit. So here's why I think maybe you would be a good candidate. For example, maybe I would look at their race or ethnicity. Maybe I would look at the number of preterm births they had. Maybe I would look to see whether they had 17p before, right? Like in a prior, with a prior, and if it was effective for them, if they felt that they wanted it again. A lot of it comes down to patient counseling, because there's a lot of patients that we offer all these things and they're just like, no, I don't want needles, or I don't want to take any medicine in pregnancy. So I think it's good to go through everything with them. So I wouldn't say it's necessarily going to change. Right now, it's not going to change completely the way I practice. The issue will be if the FDA removes it completely from the market. Then I think you do have a different counseling. You do have to take that into consideration, because now you're not prescribing an FDA medication, FDA-approved medication. You're prescribing an off-label use for 17p, which requires them to get it from a compounding pharmacy. There's financial, because it won't be covered by their insurance, so it may limit. Some patients are going to be able to get it. Some patients may not. You don't necessarily know. One of the complaints everybody has made over the years is, you know, the the compliance of compounding pharmacies with the amount of progesterone, and is it exactly the same formulation as McKenna, so can it be considered as effective? I know even with the change from intramuscular to subcutaneous, some of us have had concerns. So even though the company has said that the formulation that's used in sub-Q is very similar to IM and was proven to have the same level or bioavailability, those studies were done in postmenopausal women. They weren't done in active pregnant patients looking at the pharmacokinetics. So we need to do more data. There are lots of studies out there. A lot of people are looking at it. Dr. Kretis has a whole lab where he's looking at it. Rupsa Bolig, who's one of our Jefferson fellows, has done a lot of research looking at pharmacokinetics or bioavailability of 17P. So I think there are researchers who are interested, and that would be what's most interesting. So how much, what formulation, what level, and then that, I think, is how you could use it to titrate or decide if your patient is getting the right amount.
Okay.
The other thing that I think that needs to come out that would be great is that a few years ago, I thought it was Dr. Manick had a study where she looked at the gene loci and looked to see whether people responded to 17P or not. It's been a few years since I've read this, but that might be another way to look at
target
yes.
the right patient population.
Yes, like they've done in cancer genetics, right? So now they do genetic testing and they see whether your specific cancer is going to respond to this particular drug. They've done it with Coumadin. Should we be doing that? Maybe that's what we're missing.
Right.
Maybe there's some
Maybe it's not about race or smoking, but
something else. There's some sort of genetic component that we are missing, and that's who needs to get 17P. Okay. So I think the Prolong study this all just raises a lot of questions and not a lot of answers. Mm-hmm. In general, most people are not going to change their day-to-day counseling because there isn't convincing enough data, or I think there's enough arguments, there's problems with both studies. So we're still left in the end with 4 options for treatment.
Right. Okay. So take-home point is to adjust our counseling. Mm-hmm. Stay tuned for more information in terms of FDA approval or lack of approval for 17-OHP, and to really continue informed decision-making with our patients.
I think so. And I think the SMFM has really been on top of it. They issued their statement early in the week on Monday, and then they really encouraged all the membership, as many membership as possible, to attend the FDA meeting because they were taking public commentary. So I think a lot of representatives went down, voiced their, you get a room of MFMs, everybody's going to have a different opinion. So I think a lot of people went, voiced their opinions about it, and then I think they issued a second statement sort of reiterating that you need to counsel your patient. Like, yes, we're aware of this. We're not going to put out some sort of clinical guidance saying don't give it. Just, counsel your patients about the trial, consider their patient demographics, consider shared decision-making with them, see what they want to do. And I think that's kind of what ACOG is heading towards as well. So.
Well, great. Thank you, Dr.
You're welcome.